Good afternoon, everyone. As Dr. Chaudhary mentioned, my name is Ria Singh, and I'm a third year medical student at Kansas City University. Today, I will be giving a talk on the topic Y90 radioembolization versus drug-eluting bead chemoembolization for unresectable hepatocellular carcinoma results from the TRACE phase 2 randomized controlled trial. I chose this topic because right now I'm working as a student council member of the Society of Interventional Radiology. Presently, I along with the other committee members are working on an IR recall resource to help medical students during their IR rotation, and liver cancer and its treatment modalities available is one of the subtopic I have been working on. Before I begin, I wanted to let you all know a little bit about myself. I'm originally from India and moved to the United States for my undergraduate and medical school studies. The picture on the top left is me with my parents, and we recently visited Seattle, a place I recommend you all visiting 100%, especially if you're a space geek. The picture to its bottom is me with my friends and who are my family away from home. They keep me sane and make sure I have a life outside of medical school. As from you can see the remaining pictures on the screen, I love food and coffee, especially the Messenger coffee in Kansas City is my favorite to-go place any given time. As far as for the picture on the very far right, I love baking in my free time. Recently, I baked a coconut banana bread and it turned out to be amazing, and that is why it made to the PowerPoint today. So, now, coming back to the topic, I will briefly talk to you all about the hepatocellular carcinoma and its different stages. Presently, hepatocellular carcinoma accounts for 8% of cancer-related deaths. Its various stages are determined based on the Barcelona Clinic Liver Guidelines. These guidelines are used to predict the prognosis and plan the treatment regimen for the different liver cancer stages. So the first liver cancer stage is the early stage HCC, which is treated based on curative surgical or ablative treatment. The second is intermediate or unresectable hepatocellular carcinoma with preserved liver function, for which we use the transarterial chemoembolization, also referred to as TACE. For the advanced hepatocellular carcinoma with vascular invasion, extrahepatic spread, and tumor-induced symptoms, the systemic treatment is the plan of care. Next, I will be talking to you a little bit more about TACE and its mechanism of action. So, TACE involves selective obstruction of tumor-feeding arteries by injection of chemotherapeutic drugs such as doxorubicin and cisplatin mixed with lipidiol. It results in ischemic necrosis of the target tumor cells by cytotoxic and ischemic effects. However, the treatment does have some drawbacks. Firstly, the liquid motility of lipidiol is used for drug delivery cannot effectively reduce the effective concentration of the chemotherapeutic agents. Secondly, the various transarterial techniques are used to inject different drugs mixed in diverse concentrations such that there is no standard treatment regimen that is being followed. However, now TACE with drug-eluting beads, referred to as DEB-TACE, was developed to enhance the ability of drug delivering to target tumors while reducing the systemic toxicity and to provide a standardized embolic effect. However, various meta-analyses have shown adverse effects to be similar or slightly lower in patients receiving DEB-TACE as compared to those just receiving the conventional TACE, as shown on the screen. So in the next slide, I will be talking to you about an alternative treatment model available today to treat intermediate hepatocellular carcinoma. Today, transarterial radioembolization, also referred to as TRACE, is gaining popularity as a substitute to conventional TACE for treating intermediate HCC. It consists of selective intraarterial administration of microspheres loaded with radioactive compounds such as yttrium-90 or lipidiol labeled with iodine or radium, delivered by means of percutaneous access. So basically, as you can see here, it is these spheres of very highly radioactive substances that are injected to the tumor site, and these spheres then emit high radiation doses which are used to selectively kill the tumor cells. Now, I will be talking to you about the study itself and its hypothesis. So the null hypothesis of the study stated that there will be no difference in time to overall progression between tear and death days. The alternative hypothesis, on the other hand, suggested that tear could have either a shorter or a longer time to overall progression as compared with death days. Moving forward, I'm going to be sharing the study protocol. So the study began with 487 patients, which was screened for HCC, and the time period was from September 2011 to March 2018. Of these 487 patients, 72 patients were randomized, with 38 patients receiving TARE and 34 patients receiving the DEP test. They made up the intention to treat group. Moving on next, of the 38 patients designated to receive TARE, 33 patients actually received TARE, whereas of the 34 patients designed to receive DEP test, 36 patients actually received DEP test. DEP test and but 34 patients actually received DEP test. Sorry about that. So this contributed the per protocol group. Now, this slide tells us about the inclusion criteria and the exclusion criteria used by the study. The inclusion criteria was a Barcelona clinic liver cancer stage B or a Barcelona clinic liver cancer stage A, not amenable to ablation, partial hepectomy, or a transplant cancer, or an East Cooperative Oncology Group Performance Status 1, or a child PUG score of 7. The exclusion criteria included a greater than 50% liver involvement HCC or an HCC with an extrahepatic disease with invasion of main right or left portal vein, or a bilirubin level of more than 34 millimole per liter for the patient or over 44 millimole per liter in case of a singly involved segment. And lastly was a child PUG score of more than 7. Now, let's talk about the outcomes. So, primary endpoint was defined as the time to tumor progression, which was basically the time lapse from randomization until progression in target or the non-target lesions. Secondly, the second endpoint was referred to the whole liver and time to local progression and was defined as the time elapsed from randomization until progression in whole liver or in treated liver area. Lastly, was the progression-free survival, which was referred to as the time between randomization and death or radiologic tumor progression, whichever came first. Next, I will discuss the image findings for a patient having undergone TRACE and the other patient having undergone DEP TACE. Before I talk about the patient-specific images, I wanted to briefly review the anatomy of liver in terms of its segments. So liver basically is divided into 8 functional segments. Each of its segment has its own portal pedicel consisting of a hepatic artery branch, a bile duct, a portal branch, and its separate hepatic venous branch that provides the outflow. The segments were numbered from 1 to 8 clockwise, with 1 being the caudate lobe, then 2, 3, 4, which make up the left lobe, and 5, 6, 7, and 8, which make up the right lobe. So here in this image, I presented the image findings for a patient having undergone TRACE. He was a 64-year-old male. And in the image A is the MRI image showing 2 HCCs at the liver segment 5 and 8. So 1 and 2. Image B is a selective arteriographic image of the right hepatic artery showing 5 HCCs with 2 corresponding to those seen in the image A. So this one corresponding to this and this. So images C through E are the CT images which confirm the HCC within the arterial territory of anterior right hepatic artery. And figure F, G, and H were taken after administration of 99 m labeled macroaggregated albumin in anterior right hepatic artery and confirms the tracer uptake by the HCC. Images I and J were MRI images 3 months after the trace procedure, and they still show hypervascularity in the segment 5th and 8th of the HCC, which disappeared 6 months later. In image K is the MRI image 15 months later with no HCC identified in the radiation-induced shrunken part of the right liver lobe. Moving on next, these are the images of a 67-year-old male with multifocal hepatocellular carcinoma who had undergone DEPTase. Image A is an MRI image showing one large HCC with multiple satellite HCCs and HCCs in this segment 4. So these ones. Image B is an radiographic image of celiac trunk showing large lesion and multiple satellite lesions. This one. And image C is a CT image confirming the very HCC. Figure D is the radiographic image of one major feeder of the largest HCC. Super selective injection of 100 milligram doxorubicin loaded on the DC beads 100 to 300 micrometer was performed. Image E is the MRI taken 1 month after the second session of DEPTase. It shows central necrosis of the largest HCCs. Image F is the CT image in the beginning of the third DEPTase session, and image G is the MRI image 1 month after the fourth and final DEPTase session and proves necrosis of large HCC and all the satellite HCCs. Okay. So moving on to the results section of the study, this Kaplan-Meier plot shows the time to overall tumor progression in intention to treat group. Median time to tumor progression was 17.1 months for the TARE group, whereas it was 9.5 months for the DEPTase group. So objective response rate, which was the percentage of participants whose best response was complete or partial according to modified response criteria in solid tumor in the liver, was found to be 88% for the TARE as compared to the 100% for the DEPTase group. Next, we will be talking about the per protocol group. This plot shows the time to overall tumor progression for the per protocol group. The mean time to tumor progression was 17.1 months for the TARE group, whereas it was 9.5 months for the DEPTase group. Now, we will be talking about the results of the overall survival outcome. So, this is the overall survival outcome for the intention to treat group. It was found the overall survival, first of all, was defined as time between randomization and death from any cause. The median overall survival for the TARE group was 30.2 months, whereas for the DEPTase group, it was 15.6 months. This Kaplan-Meier graph shows the overall survival in the per protocol group. The median overall survival was found to be identical to the intention treatment group, such that it was 30.2 months for the TARE group and 15.6 months for the DEPTase group. Next, I will be highlighting the key discussion points of the study. Firstly, it was found that TARE resulted in a significantly slower tumor progression in comparison to the patients who have undergone the DEPTase method. Secondly, the local tumor control was much more durable with TARE as compared to DEPTase. In DEPTase, the time to local progression was found to be significantly shorter. Thirdly, participants in the TARE arm had significant survival benefit, and it was believed to be attributed to the success in downstaging to the autotrophic liver transplant. Lastly, I will be talking to you about some of the study limitations and future considerations. Firstly, the procedure of patient accrual was very slow, such that the study expanded over a total of 7 years, and of the 487 patients that were actually screened, only 72 patients are actually included in the study. Secondly, no personalized dosimetry was applied for the DEPTase arm of the randomized study trial. Next, talking about some of the future considerations, one thing we can focus on is the preemptive treatment of the peri-tumor liver tissue, regardless of the small bead size. And secondly, it would be advocate to consider using investigational biodegradable drug-eluting beads in the lobar treatment with an acceptable risk of parenchymal damage for equivalent anti-tumor activity. And these are my references. Thank you so much for taking the time to listen to my presentation. If you have any questions, let me know.